Hi everyone, we get started. Alright, thank you for coming along to the first Long Case Masterclass. My name is Trung. I'm the Education Officer. So firstly, I would like to thank our two speakers, Lucy Collins and Boaz Kim, for being generous with their time to come to speak to you guys. Lucy Collins was the RMH Long Case winner last year, and Boaz was the St. Vincent's Dean's Honours List 2013 and 2014. So both of these guys did really well in their long cases. So Lucy will be doing a medical long case, and then Boaz will present a surgical long case. I would like to thank the two MD2s on my education subcommittee. We have Lisa and Victoria. They've really driven this event, so thank you so much. And now I'd like to invite them up to tell us the schedule.
To start off, we've got two parts today. The first part will be long case presentations, firstly by Lucy, which, as you know, is a medical long case. She'll then break down the long case in detail, and we'll have a few questions at the end for her as well. This will be followed by Boaz, who'll be doing a surgical long case, and he'll do a similar breakdown with some questions too.
Hey everyone, so part 2 is when you'll if you have any burning questions, you can ask at that time. And they'll also be just giving general tips about how to go about your long case, and also on the day, like what you can do during the 10 minutes, and just to prepare, writing up and things like that. So hopefully get your questions ready for them. Thanks.
Okay, so first up, we'll welcome Lucy Collins.
Hi everyone. My case is the one that I presented for my second long case last year. So all the dates are a bit weird, so just pretend we're in 2014. All right. So, and also I'm calling my patient JM because I didn't want to say her name. So JM is a 21-year-old woman from home with her family who presented to Royal Melbourne Hospital on Thursday the 21st of August following 2 days of right-sided abdominal cramps and pain, nausea and vomiting, and blood and mucus in her stools in the context of Crohn's disease on a background of anemia and vitamin D deficiency with a past medical history of Henoch-Schönlein-Purpura. JM presented to Royal Melbourne Hospital following 2 days of right-sided abdominal cramps and pain, nausea and vomiting, mucus and blood in her stools and fevers. In regards to her abdominal cramps, they came on suddenly on Wednesday morning in her right lower quadrant and radiated to her back. She described the cramping as sharp, and initially the severity was 10 out of 10, however fluctuated over the 2 days from 3 out of 10 to 10 out of 10. She didn't try any medications to relieve the cramping, however she found that movement exacerbated it. This was associated with right-sided flank pain that also radiated to the back, that came on suddenly whenever the cramping was severe. She described the pain of a stabbing quality that was severe at 10 out of 10. She attempted to relieve the pain with paracetamol, however to no avail. It was also exacerbated by movement. She did not experience any associated urinary symptoms with this pain, namely no gross hematuria, dysuria, irritative or obstructive symptoms. She also vomited multiple times on the Wednesday and Thursday prior to her admission and felt nauseated. The vomitus contained food and fluids. There was no hematemesis. She tried metoclopramide, however this didn't relieve the nausea and vomiting, and nothing seemed to exacerbate it. At this time, she had no symptoms consistent with infective gastroenteritis, namely no sick contacts, no unusual foods consumed, no recent travel, and no associated diarrhea. JM also noted hematochezia on Wednesday and Thursday. This is not abnormal for the patient, however she did describe the blood as more pronounced than usual. The blood was separate from the stools, and I note that there was associated pain on passing the stools, which was also increased by straining. An orange mucus was also noted in her stools. It was found in the toilet paper and on the toilet bowl and on toilet tissue. Again, this is something that she always finds in her stools, however, again, it was more pronounced. She was febrile as well prior to presentation on Thursday with a temperature of 37.2. Relevant to her history of presenting complaint is a previous admission to Royal Melbourne Hospital 1 month previously for an acute exacerbation of her Crohn's disease following a 1-day history of intense vomiting and right-sided severe abdominal pain. Now, in regards to her progress in hospital, she's been rehydrated with intravenous fluids, and her constipation has been managed with various aperients, including a fleet enema, caloxylin senna, lactulose and robocol. Her abdominal pain has been managed with a triad of paracetamol 1 gram QID, endone 5 to 10 milligrams as needed, and morphine 2.5 to 5 milligrams as needed. Her Crohn's management in hospital has included 20 milligrams Marne prednisolone, pantoprazole 40 milligrams in the morning, and for symptomatic relief, metoclopramide and ondansetron. She has been prescribed enoxaparin 40 milligrams daily to prophylactically manage deep vein thrombosis. She has had a CT scan and a colonoscopy that revealed 10 centimetres of inflammation of the terminal ileum. Her current hospital admission has been complicated by hypokalemia with a value of 2.9 that resulted in heart rate abnormalities. She felt dizzy during this time, and she's currently taking slow K. Yesterday, when I saw JM, she was day 7 and about to be discharged. Her abdominal pain had decreased, however was still present. The nausea and vomiting had dissipated, and she was finding less blood and mucus in her stools. She has had daily bowel movements. She's been prescribed 25 milligrams daily of mercaptopurine to begin at home, as well as a combined oral contraceptive pill. Now, in regards to her past medical history, the first thing I'd like to discuss is her Crohn's disease. This was diagnosed in 2012 following 6 months of progressively worsening right-sided moderate to severe abdominal pain, constipation with intermittent diarrhea, and mucus and blood in her stools. She had associated fevers and weight loss during this time. At her lowest, she weighed 54 kilos with a BMI of 17. Dr. Quesh diagnosed the Crohn's following a colonoscopy that revealed multiple pathologies in the terminal ileum, including strictures, ulcers, a stricture that was 2 centimetres long, and 5 centimetres of inflammation. The initial plan for treatment was azathioprine, however this was refused by the patient as she has a family history of Hodgkin's lymphoma and was concerned as to the side effect profile of azathioprine. At the start of 2013, she was prescribed 25 milligrams daily of prednisolone and mesalazine to manage her inflammatory bowel disease. She took the prednisolone for 2 months and noticed various side effects, including an increased appetite, acne, and a round face. The mesalazine was continued for the whole of 2013. This treatment was, however, unsuccessful in relieving her symptoms of Crohn's. In 2014, her Crohn's was untreated apart from symptomatic relief with paracetamol and mobicol. At home, she's currently symptomatic with her Crohn's, predominantly mild diffuse right lower quadrant pain, blood and mucus in her stools, constipation with intermittent diarrhea and bloating. I note that she suffers from no extra gastrointestinal manifestations of her Crohn's, and she's had 2 presentations in 2014 for acute flares of her Crohn's, 1 a month ago, and her current admission. Following her discharge from Royal Melbourne, the management will include mercaptopurine and prednisolone in conjunction with a low residue fibre diet. Dr. Shivasanan at Royal Melbourne currently manages her Crohn's, and she's planned to visit the inflammatory bowel disease clinic at Royal Melbourne monthly. She has no family history of IBD or colorectal cancer. Secondly, she has some nutritional deficiencies. The first one I note is anemia. This was diagnosed in 2003 following routine blood tests. The etiology of her anemia is multifactorial. She's iron deficient, secondary to both her Crohn's disease, resulting in malabsorption, and also the chronic blood loss that she experiences. And she also has extremely heavy menstrual periods. This is in conjunction with also vitamin B12 deficiency and anemia of chronic disease. She received an iron infusion in 2013 and a B12 injection during this current admission to manage this, the anemia. The patient regularly feels fatigued and tired, however she experiences no associated shortness of breath or palpitations. This is currently managed by her local GP. She also is vitamin D deficient. This was also found out on a routine blood test in 2013. She's experienced no bone pain or fractures, and this is managed with 1,000 units in the morning of cholecalciferol. JM also has henoxyl purpura, or has had HSP. This was diagnosed in 2003 at RCH, following an acute history of bilateral edematous hands, fever, bilateral purpuric rash of the lower limbs, swollen ankles, and severe abdominal pain. At that time, she was also diagnosed with juvenile rheumatoid arthritis and associated glomerulonephritis, as blood and protein were found in her urine. She received treatment of prednisolone and a 3-month treatment course of azathioprine. This was managed by a paediatrician, Dr. Harley. Between the years of 2003 to 2008, JM was symptom-free of HSP. However, in 2008, she experienced a second episode of a diffuse purpuric rash over her lower limbs, abdominal pain, predominantly in the flanks, and blood and protein were also found in her urine. Again, she was treated for 3 months with prednisolone and azathioprine. In 2010, she experienced a third episode of the bilateral purpuric rash of her lower limbs. However, there was no joint, abdominal or kidney involvement. Again, prednisolone was prescribed for 7 months. This condition is currently not being actively managed, and she has no family history of henoxolon purpura. Lastly, I'd like to quickly discuss JM has suspected endometriosis. She has a significant history of heavy, painful menstrual periods that are both irregular and frequent. Menses was at age 13 and was initially painful and heavy, however regular at approximately 28-day cycles. From age 15 to now, her periods have been very heavy. She experiences clots, pads overflow, so much so that she needs to change clothing. And they're also frequent, with her cycles becoming as short as 14 days. The bleeding lasts approximately 4 days. A combined oral contraceptive pill has been commenced during this recent admission in a bid to control her menstruation. She has no personal or family history of any prothrombotic conditions. In terms of her allergies, I note she's allergic to penicillin, for which she gets a rash. And this year, JM has had the measles, mumps, rubella, varicella and pertussis vaccines in the context of her course and working in childcare, and she's up to date with all her other vaccinations. She had the flu vaccination for this year. She's never had a pap smear nor been screened for bowel cancer. Of note in her family history is diverticular disease, Hodgkin's lymphoma, irritable bowel syndrome and type 2 diabetes. In regards to her social history, she lives with her mum and her twin brother. Alone is making her anxious and emotional. There have been family problems in the past, however JM feels stable at home with her mum and brother. Systems review was unremarkable. Now moving on to my examination, JM is a young woman orientated to time, place and person. She's appropriately interactive and appeared relatively comfortable lying in bed. Her weight was 63 kilos, height 174 centimetres and she had a BMI of 20. She was hemodynamically stable. On general inspection of her abdomen, there was some bruising inferior to the umbilicus. On light palpation, there was tenderness on the right side of her abdomen. The tenderness was diffuse and she stated that the pain radiated to her back. There were no signs suggestive of peritonitis. She had no hepatomegaly or splenomegaly and her kidneys were not blottable. Bowel sounds were present and loud, and she had no peripheral signs of Crohn's disease, namely there was no evidence of arthritis, erythema nodosum, clubbing or any ocular changes. Cardiovascular and respiratory exam were also normal. There was no peripheral lymphadenopathy, and a brief neurological screen revealed no abnormalities. Power, tone, sensation and coordination of both upper and lower limbs was normal. So in summary, JM is a 21-year-old woman from home with her family that presented to Royal Melbourne Hospital following an acute flare of her Crohn's disease. Following 7 days in hospital, the abdominal pain has partially resolved, the nausea and vomiting has subsided, and she has noticed less blood and mucus in her stools. Upon discharge home, her medical management of her Crohn's consists of mercaptopurine and prednisolone, and a combined oral contraceptive pill has been added to manage her heavy menstrual bleeding. Now, before I move on to my issues today, I'd like to discuss my potential differential diagnosis and subsequent investigations had I seen JM initially when she presented to Royal Melbourne Hospital, febrile with abdominal pain, nausea and vomiting, and mucus and blood in her stools. So clearly with her past history of Crohn's disease, I would have a very high index of suspicion that this presentation was an acute flare of her Crohn's. However, I would also consider and rule out an infective colitis, appendicitis, and also as she is a woman of reproductive age, although she said she's not sexually active, it would be important to rule out an ectopic pregnancy in a woman presenting with abdominal pain. So in regards to investigations that would be pertinent to these differentials, initially looking at bloods, I'd like to do an FBE looking at her hemoglobin and her white cell count. I'd like to do a UEC looking for any signs of dehydration or impaired renal function. Coagulation studies would be important as she is currently bleeding. And also stool MCNS and OCP looking for any infectious or pseudomembranous colitis. Lastly, I'd also like to do a beta HCG to rule out an ectopic pregnancy. In regards to imaging, I would be initially cautious because she has received a lot of imaging in the past. However, a CT would be beneficial to locate any inflammatory bowel disease pathology and also to look at the health of the appendix. Lastly, of course, definitively a colonoscopy would be good with or without biopsy to look for any IBD pathology. So now moving on to my issues for this case, I have 4 issues I'd like to discuss with you today. The first being the management of her Crohn's disease, the second being the complications of her Crohn's disease, thirdly, the ongoing management of her other medical problems, both past and present, and also lastly, a psychosocial issue, the impact of her chronic disease on her mental health and emotional well-being. Would you like me to begin with my first issue?
Yeah, sure.
Okay. So in regards to the current management of her Crohn's disease, I think there are three things that are important to look at. The first being the short-term, medium-term and long-term management of her disease. So short-term, her goals of management would be to induce remission from this acute flare with the steroids that were prescribed. However, it would be important to make sure that the patient is weaned off the steroids as soon as possible, as there are severe side effects from these, and also to encourage Jamie to continue her abstinence from her smoking. Looking at some medium-term goals of management, obviously we want to prevent relapses from happening in the future and to maintain this remission. So currently, to do this, we're doing some immunomodulatory therapy with the mercaptopurine, but her specialist might have to look at some other therapies, namely some anti-TNF inhibitors. Lastly, long-term goals of management. I think it's important in this case to prevent complications and to look at what might be happening with the Crohn's disease. And I'd like to talk about that quickly in my second issue, which is the complications of her Crohn's disease, if you would like me to, or else I can move on to my psychosocial issue.
Yeah, that'd be good. Yeah, the complications of Crohn's. Can you go through that briefly before we move on to psychosocial?
Yeah, sure. So just quickly, as I said before, she has various nutritional deficiencies which are linked with her Crohn's disease and also her heavy menstrual bleeding. So it would be important for her to have a really good relationship with her local GP. So these are monitored regularly with FBEs and also looking at, say, her folate B12 levels, things like this. Also, I'd like to make sure that she's getting the absorption of, say, her fat-soluble vitamins as well. What else do I want to say? Also, looking long-term in this patient, I'd be concerned about a form of metabolic bone disease. Like, we know that Crohn's is a lifelong condition. And as she ages, obviously her risk profile will increase, especially when she passes through menopause. So addressing those factors early would be important. So looking initially at lifestyle modifications, weight-bearing exercises. She takes vitamin D, but making sure her diet's high in calcium, and then monitoring this with various investigations and also, when necessary, DEXA scanning. And also, people with Crohn's disease are at high risk of bowel cancer. She doesn't have a family history of colorectal cancer, but it would be pertinent to perform colonoscopies regularly to monitor for this. Now, lastly, very quickly about, it's always really important, guys, to do a psychosocial history, psychosocial question. So the impact of her chronic disease on her mental health and emotional well-being. As stated in my social history, she's currently struggling with this, and she finds it hard to get through the day at university. So I think it'd be really important in a patient like this to maybe put her in touch with some patient support groups and also some patient education, and just make sure the GP is managing this issue and potentially get some counselling services in place for her.
Thank you.
Great. Alright, so really quickly, because it's long and kind of boring. Alright, so I use a manila folder to do my long cases on. This is obviously a piece of paper, but that's fine. The way that I do it, I fold it in half like this. So you write your introduction, your medications all down there, and then your associated allergies. And then once you open it up, you've got all your information. So I do my history presenting complaint over on the left, and then my past medical history in the middle too, and then family social and all my vaccinations and screening things on that side there. And then on the back, sorry about the poor picture, there are my examination findings, all my differentials, and then the issues that I'd like to discuss with the examiner. So, my long case breakdown. So I start with my introduction where I say, who it is, where are they from, what are they presenting with, and this is either like in the context of, on a background of, with a past medical history of, blah, blah, blah. Then you move on to your history presenting complaint, which I'm sure you can all do very well. In this case, there are a lot of presenting symptoms. It wasn't simply shortness of breath or something like that. So the way that I like to do it is to break it up really clearly for the examiner and just to move through each one, looking at the main parts of that. And then I think it's also important to include in your history presenting complaint relevant negatives to show the examiner that you are thinking about differentials from as early on as the history presenting complaint. So I talked about flank pain and no associated renal symptoms, and I also said with the diarrhea, so with the vomiting, there was nothing suggestive of a gastroenteritis, an infected gastroenteritis. And that's obviously really important if you're doing like a bread and butter chest pain, which I'm sure Boaz is doing something along those, maybe not. If you're doing a chest pain history or a shortness of breath, show that you're thinking about other things and not just going straight for the MI or whatever it might be. So progress in hospital, I like talking about acutely how she's been managed, how have her symptoms been managed. Investigations in hospital, the patient might not know what's happened, or they might not know in depth. Like my patient was a nurse, so she was all over her investigations and what they showed, but that's not always necessarily the case, especially if you have an 80-year-old slightly delirious patient. And then if there are any complications and what happened, how did they manage them? And then I think it's also really nice at the end of your history presenting complaint to paint a bit of a picture to the examiner. How's the patient doing? Have they improved? What's kind of going on when you saw them? So that's what I've done there. Then past medical history. This is the way that I always do it, and it means that for anything that a patient might have, if you just work through this systematic algorithm, it always works out. So you basically want to know, when was it diagnosed? Were they symptomatic at this point of diagnosis, or was it picked up routinely? Who diagnosed it? How was it diagnosed? And the initial treatment that they received. And then were there any complications of that initial treatment? What are they currently doing for their condition? Is it active? So are they currently symptomatic? And then looking at the broad complications of that medical condition, and then thinking about any risk factors or positive or relevant, things in their family history. And if you kind of use that for every single condition that a patient might have, it works out really nicely, and it means that you won't really miss anything. All right, medication history and allergies. I think it sounds really nice if you try and include all your medications in their history presenting complaint and past medical history, as opposed to rattling off a long list at the medications part. And allergies obviously ask what happened, and also in an elderly patient, ask about like how are they dispensing their medication. Do they have a Webster pack? Is someone setting it up for them? Because that's pretty important for them going home. And then I also like to ask about screening and vaccination or immunisation. So I routinely ask breast, prostate, bowel and cervical screening, obviously the right ones for the right gender. And then are they fully immunised? How they obviously pretty important in an elderly person. Now family history, only do what's relevant to the case. Don't talk about the maternal aunt with some ridiculous thing. Social history, I think that you guys just do it the way that you want to do it. Make sure that you include certain things, obviously. And I think in the elderly, I like to ask about all the ADLs, so personal, community and domestic, because they're really important for putting that person back in the family home. And also steps in the home and outside, and who's looking after you at home, is there any carer stress, things like that. Now systems review, contentious, I don't do one, that's fine. Make up your own mind about that one. I don't think there's time in a 1 hour long case to go through every single system, but yeah, it's contentious. Maybe Boaz has a different opinion. In terms of the examination, I like to set the scene for the examiner, as I've done up here. I always use those sentences, obviously if they're appropriate, you use them. Vitals. I was in this case because I was running late, and I just said hemodynamically stable. I think that suffices. Obviously tailor the exam to history presenting complaint and past medical. I think we'll talk about this a bit later on in terms of you only have an hour at the end of the year, so you really have to do what's important. So I went straight for the abdomen in this case, but just quickly mentioned that I did have a listen to the heart, the lungs, and I did a quick neuro screen. Also, I like to include a few relevant negatives there to just show the examiner that you're thinking when you're doing the exam, to show off a bit of knowledge. Summary, keep it sweet, short and sweet. What do you think it is? Are they improving? What's going on? If there are examination findings that are relevant, include them here. All right. Now, the way that I set up my long case, I'm not sure if you guys this year are marked to include investigations in your long cases, but we were. So I like to do 3 to 5 differentials and then move on to what pertinent investigations I would do for those differentials. So obviously if something's really obvious, say it. If it sounds like an MI, say my number one suspicion would be an MI, however I would like to rule out blah, blah, blah. And then the way that I like to do my investigations, it sounds really clear if you say, so starting with bedside investigations, I do this and this and this, then I move on to blood, then imaging. And also I think it's important here to quickly state what you might be looking for. So say they come in short of breath, I'd like to do a chest x-ray, looking for any, signs indicative of pulmonary edema, pleural effusions or curly B or whatever. And then, or pneumonia, like a lobar consolidation. And if you do it like this, then you say, so the way that I've always set up my long cases, I say my differentials and then I say, I've got 4 issues I'd like to discuss with you today. And then you go through them and then you say, would you like me to start by discussing my first one? And they basically always, well they did for me, they just said, okay, yeah, let's just discuss that. So that you don't give them much scope to actually ask you a question. It works. Yeah, because Boaz is going to go more into the question part of the long case because I was actually never really asked a question in my long cases. Because if you follow going through differentials, investigations, what are my issues, and then I'd like to talk with you about my first issue, they go, okay, let's talk about it. And also, don't be too worried about the question part. For my end of year long case, I had a crazy neuro case with like a weird AVM or something on the spinal cord. I was being examined by an endocrinologist. She'd never even heard of it, so she said, all right, Lucy, see you later. That sounds good. So, they'll ask you stuff that's common, but don't worry about the really minor, hard things. They're pretty fair. And then if you're clear about all these other things, like your history presenting complaint, your examination findings, they're not going to ask you about it. So it's good if they don't ask you many questions to clarify, I think. All right. Boaz, your turn.
So I prepared this is a long case that I did last year, and it's a bread and butter cardiac case, but I chose a bread and butter one because it's probably easier to convey the important stuff in a long case using a simpler, it is complex, but it's we should all know about this case. So yeah, let's make a start. So Mrs. Florence Richardson is a 74-year-old lady from Traralgon who is day 2 preoperative admission for an aortic valve replacement scheduled for tomorrow afternoon. This is on a background of childhood rheumatic heart disease, a 50-pack-year smoking history, type 2 diabetes, hypertension, and a 6-month recent onset of decompensating symptoms of heart failure, including exertional dyspnea, lethargy, ankle edema, and palpitations. Mrs. Richardson is known to St Vincent's cardiology with severe aortic valve disease and has been monitored with annual transthoracic echocardiography over the last 15 years. In further detail of her presenting complaint, she has been experiencing worsening shortness of breath over the last 6 months. 1 year ago, she could walk about 800 metres. 6 months ago, she had difficulty walking 400 metres around her street. Currently, she can only walk 50 metres on flat surfaces before needing to stop and rest. She has had paroxysmal nocturnal dyspnea, waking acutely from her sleep on most nights over the last 3 months, has orthopnea requiring 3 pillows, but experiences no shortness of breath at rest, which gives her a New York Heart Association Class 3 on her current functional capacity. She has had worsening lethargy interfering with her daily life. Having been playing lawn bowls for the last 20 years, she stopped playing 3 months ago. She lacks the energy to clean the house. She describes having to take breaks in between making her bed. She has also had swelling in both legs extending to her knees in the past 12 months, but this doesn't currently impact on her degree of mobility. When asked about palpitations, she described having fluttering sensations that came and went intermittently over minutes, with no apparent precipitant. She hasn't experienced any syncopal episodes, but has had several isolated episodes of lightheadedness associated with physical activity. She has had no change in weight or appetite, no constitutional symptoms of fevers, chills or rigors, no calf pain or previous history of clots, and no symptoms of coryza, productive cough or hemoptysis in the last few weeks. Her active medical history, she has type 2 diabetes, diagnosed 10 years ago incidentally on a blood test. She's been managed with diet and exercise over the years and was well controlled until about 1 year ago due to her reduced exercise tolerance. And so she's been put on metformin 500 milligrams daily for 10 months and is adherent to therapy, monitors her blood sugars regularly, and complains of no complications of diabetes. Hypertension, she was diagnosed 15 years ago, for which she is taking candesartan and hydrochlorothiazide, 16 and 12.5 milligrams daily, and has regular GP reviews. Hypercholesterolemia, diagnosed 15 years ago, also incidental diagnosis. She's on rosuvastatin, 20 milligrams, and fenofibrate, 60 milligrams daily. She also has chronic obstructive airways disease, diagnosed 8 years ago on pulmonary function tests, for which she takes salbutamol as required and serotype 250/25 micrograms metered dose inhaler daily. Complications of her COPD, she had a pneumonia 4 years ago requiring IV antibiotics, corticosteroids, and hospitalization. She also had 2 infective exacerbations in the past 12 months requiring oral antibiotics. She has a hiatus hernia with associated gastroesophageal reflux. This was diagnosed 8 years ago when she presented with reflux symptoms. She's on 20 milligrams pantoprazole daily. Reflux symptoms are well controlled. Past medical and surgical history: childhood rheumatic heart disease when she was 8 years old. She had a right total knee replacement in 2010 and a hysterectomy for uterine prolapse 8 years ago. Medications allergies: apart from the medications already mentioned, she is also taking sertraline, 15 milligrams daily for depression. She's been taking this for 2 years. She's also on low-dose aspirin, 100 milligrams daily, which has been ceased since her admission in preparation for her surgery. She has no known drug allergies. Family history: father had hypertension, diabetes, and died of a myocardial infarction. She has no family history of cancer. Immunizations: she's up to date with the flu vaccination and pneumococcal vaccination. Screening: she's 74, doesn't fit the criteria for regular screening tests anymore. Social history: she's retired, lives alone in Traralgon. She's able to drive, and up until recently she was independent with her groceries, her cleaning and leisure activities, which was mainly 3 times a week going to play lawn bowls. Occupational history: she worked in a sawmill factory for 20 years and she was exposed to various airway irritants. She has 50-pack-year smoking history, as mentioned. She stopped 15 months ago due to deteriorating respiratory symptoms. She doesn't drink any alcohol. In terms of her mood, her psychiatric history, her mood has been stable. She is positive about the surgery, optimistic about the future, no suicidal ideation. She's well supported by her 3 daughters. So I examined Mrs. Richardson mainly with respect to the cardiovascular system. So on general observation, she was a well-appearing, thin-looking elderly lady, alert and oriented. She was sitting up comfortably in her bed. No signs of respiratory distress. No oxygen mask or sputum mud was present, and no peripheral IV lines were in at the time. She was afebrile and vitals were stable. Rest rate 14, blood pressure was 130 over 85 lying, and 120 on 70 standing, so that there was no observed postural drop. Peripheral examination: her pulses were regular, slightly bradycardic at 56 beats per minute, no peripheral stigmata of endocarditis, normal capillary return. She had no conjunctival pallor or cyanosis. Carotid pulses were regular, of low volume and slow rising. No bruits were heard. Her JVP was 3 centimetres. On precordial examination, there were no chest wall scars visible. Her apex beat was forceful but wasn't displaced. There were no palpable thrills or heaves. She did not have any features of a barrel chest. On auscultation, the most salient finding was that of a coarse ejection systolic murmur, heard loudest at the right upper sternal border, radiating to the right infraclavicular region and up to her carotids. This was associated with a softer S2 sound and no radiation to the axilla. No diastolic murmur was heard at the left lower sternal border on full expiration. There were dual heart sounds and no added sounds. On auscultation of the lungs, she had a fine bibasal inspiratory crackle and reduced air entry bilaterally. There were no signs of pleural effusion. She had no evidence of peripheral pitting edema when I examined her, and she had venous skin changes bilaterally on both legs. Her abdomen was soft non-tender. There was no evidence of hepatosplenomegaly. Brief hematological examination was unremarkable with no bony tenderness or lymphadenopathy. Neurological exam was grossly normal in all 4 limbs. So in summary, Mrs. Richardson is a 74-year-old lady due for a bioprosthetic aortic valve replacement tomorrow afternoon on a background of decompensating symptoms of heart failure secondary to known severe aortic valve disease. Physical examination revealed a coarse ejection systolic murmur heard in the right upper sternal border, radiating to the right carotid region, and together with a softer S2 sound and slow rising pulse, carotid pulse, this seems to be in keeping with a moderate to severe aortic valve stenosis. So my differentials for Mrs. Richardson's presenting complaint of exertional dyspnea firstly would be decompensated heart failure secondary to her valvular disease. Secondly, cor pulmonale secondary to her COPD. And thirdly, a chest infection given her previous history of respiratory tract infections and her COPD. So onto her management. In the short term, I'd like to confirm her diagnosis and evaluate the extent of her valvular disease. I'd like to do a transesophageal echocardiogram looking at her left ventricular ejection fraction, her myocardial contractility, and the degree of stenosis across the valve, and for any other regurgitant pathologies. I'd like to identify and correct any reversible causes of her decompensation. So looking at her hemoglobin, thyroid function tests, troponins, screening for infections, including a urine test, which did come back as positive and was treated during her admission, an ECG, given her history of fluttering sensations, and also just checking on her compliance with her medications. Thirdly, I would like to request an anaesthetic assessment for her preoperative testing, also achieving normoglycemia leading up to the surgery. So she's currently on metformin, so I would seize that 12 hours before the surgery, monitor the blood sugars, and put her on an insulin sliding scale. Post-operatively, looking at analgesia, DVT prophylaxis, antibiotics, wound care, and early mobilization. The other important thing with Mrs. Richardson is that she's currently living alone, so her discharge plan should ensure adequate support in place before she moves home. Medium to long term, would review her in cardiology outpatients, assess her mobility and functional state, so occupational therapy, physiotherapy as required, correspondence with GP, and also monitoring and managing her cardiovascular risk factors. Psychosocial management, offering counselling as required, and reviewing her antidepressant sertraline medication routinely for any side effects. So that's the Long case. This is my manila folder template. So I have, on the first page, I've got introduction, history of presenting complaint, risk factors and a systems box. I put the risk factors there because as you take the history, you can chuck in your any relevant risk factors and then just on a background of and list all of them. It's really easy. At the bottom, as Lucy did, I have a progress or current admission section. So you can see on the left there's investigation. So you just ask them like what investigations, etc. I'll cover this later actually. Management, complications, any problems since her admission, and the plan forward, if you know what's happening. Second page, this should be a bigger section. Her active history would take up more space. There's past med and past surgical. Meds and allergies, family history, immunizations. I always forget screening, so I put it here. Well, and then social history, and on the third page, a lot of room for this examination. Some people like to put their progress notes here, so what's been happening just before they go into their differentials. And then my fourth page on the manila folder is my 3 differentials and my management short-term, medium, long, psychosocial. So let's just break down what I did in my long case. Basically, you provide the patient info and you need to address why they are actually in hospital. So, for example, this is a good tip. So, why are they in hospital? Example, they're day 2 post-renal transplant, they're undergoing investigation for ... They're admitted for ongoing management of day 3 post-acute kidney injury. They presented with X, Y, and Z symptoms and are being investigated for. So you'll either get a management case or an investigation case. So make that clear. You can just make that really clear for the examiner. History of presenting complaint. My tip would be you really need to characterize the history and progression of symptoms carefully. So like 2 years ago, how were you? 1 year ago, 6 months ago, 3 months ago, now. You know, gives them a really good picture of their functional status. And the other thing you know, you could try to do is to be more distinct and stand out. You can add clinical interpretation or comments. So this gives her a New York Heart Association Class 3. So if you haven't looked through that, it's really easy to remember. So just have a read through that. Continued. Relevant negatives at the end, as Lucy was doing. This demonstrates to the examiner the differentials you are entertaining without even having to state them. So do you remember her symptoms? It was dyspnea, ankle swelling. She had heaps of smoking history, other cardiovascular problems. So when I said she has no lost changes in her weight or appetite, no constitutional symptoms, etc., the loss of weight, appetite, constitutional hemoptysis, I'm saying lung cancer. Fevers, chills, productive cough, coryza, I'm saying respiratory tract infection. No calf pain, hemoptysis, DVTP. So it's like a subtle but recognizable way of saying, I think this patient has decompensating heart failure due to whatever, and not less likely due to cancer, pneumonia, or PE. So, and then again, the progress, current admission, I just think of it as 3 or 4 things. You can just ask the patient, since you've been admitted, what tests have you had? If they're sort of struggling and not a nurse, then, you know, any x-rays, any blood tests, and any other scans. And it's okay if the patient doesn't really know, you can just say that. They had some blood tests. You're basing it off what they tell you. Management, what's been done for you so far? And you know, and they're lost for words, antibiotics, analgesia, etc. Any problems since you've been in? And then, do you know, what's your understanding of the treatment plan? And that gives a really good overall snapshot to the examiner of where the patient's at currently. Then we go on to the medical history, so just split it up into active and past. Active is disease A, diagnosed when, how, symptoms then, now, treatment / management, control. So insert your medications here. Complications of disease. So example, I use COPD, diagnosed 8 years ago. She takes salbutamol, serotype, complications, pneumonia, etc., etc. So you can just follow that format as Lucy was doing for each disease. And obviously for past medical, like surgical, you don't need to do it to that much. You know, she had a total knee replacement in 2010. That's fine. Medications, apart from the medications already mentioned, she's also taking, just do that, saves time. Family history, keep it really brief. They don't want to hear her uncle had rheumatoid arthritis and the daughter has eczema, hay fever, unless it's really relevant. So, immunisation screening, I put this slide in like 10 minutes before we started because I keep forgetting, but that's, I guess, important. And social history. Oh yeah, I usually put it in there, but then I cave to other people saying, oh, you should keep it separate.
That's contentious at the moment.
Yeah, okay, well, another contentious thing. Social history, yeah, living arrangements. What do they do for work? Normal activities. You know, for this patient, lawn bowls is really important. So, and if you're living alone, living with others, smoking, alcohol, always ask about mood and depression. And if positive on screening, you know, duration, suicidal thoughts. Occupational history plus minus, you know, if it's relevant. If it's like a rest case, yeah. Cardiac case, maybe. Neuro, no, maybe not. Physical examination. So start general observations, vitals, start with and focus on the main system. A lot of people ask, do you need to cover every system? Probably not. Examination is guided by your history. So you could, for example, you do your main system really thoroughly, but then you can do a quick, like, when I said like neurological system, like grossly normal, it was like really quick screen, just like move them around, move their legs, and if it seems normal, you just say grossly normal. But if the history suggests that maybe it's a lung cancer going, you know, mets to the brain, or she had symptoms of headache, nausea, vomiting, then you might want to do a more close neurological examination. So it's guided by the history. So main findings, So in a learning point from this case would be learning the murmurs and features of a murmur. Loudness of a murmur is not an indicator of severity, but there are other markers that are more suggestive. Relevant negatives, so for example, I said no radiation to the axilla. That is, I think it's an AS murmur, not MR. Things like that. Summary, keep it succinct. Summarise the history, summarise the examination findings, and where possible add in clinical interpretation. So this appears to be in keeping with whatever. Don't be like this is, because then you'll get grilled. Differentials, I just go list 3 from most likely to least. For her, those were the 3. Management, 3-tiered. Short-term, medium to long-term, and psychosocial. And even if the patient doesn't have a diagnosis of depression, that's okay. Any patient with chronic or severe or acute illness requiring admission, that is most, if not all, long case patients should be screened for mood or depression problems. And then just say, if in doubt, just offer counselling as necessary. And, if they have problems with finances, accommodation, social work review, so know your allied health and what they do. Falls risk, physiotherapy, occupational therapy, things like that. Possible examiner questions for this case would be things like preoperative and postoperative issues and complications. I think you guys get a lecture on that, and I just remember just memorising. There were only like 7 or 8 post-op complications. Just memorise it. Find a weird mnemonic, and then just how to assess the patient's fluid status. Questions about your differential. So in my long case, in my actual long case, I got a respiratory case on aspergillosis. And the good thing is you don't actually have to know anything about it because they don't really know either. And I got asked how to differentiate between pneumothorax, PE, cardiac, respiratory sort of causes. He's like, oh, so what investigations would you do on a chest X-ray? What would you see on a chest X-ray? I'm like, I don't know, you just waffle and hope that you. But so be prepared. If you're going to give differentials, be prepared to justify it and how to differentiate between those. General questions, it's always, pain management, assessing nutrition. Specific questions to this case would be severity of the valve disease, when to treat, when they start decompensating, you treat them. Treatment options, like open heart or via the thing, TAVI, something. And then the causes of AS, know that. Complications of AS. And then know the causes of decompensation. I'm sure everyone's done Mad Hatter. Mad Chatter, just with compliance, just to help you, people who reduce their dose or just stop taking medications. Okay, so that's that, and then we can move it.
So my tips for long cases, use a manila folder if that's what works for you. On the day they give you a clipboard with pieces of paper if that's also how you do it, so whatever works for you. But make sure that if you find something that works, you actually practice with it. And it's also important to start practicing presenting directly off the folder, because as nice as it is to go home, type it up all nicely and then present to a friend or a registrar the next day, that's not actually how it's going to be when you guys do it at the end of second semester. So it's good to start practicing talking on the spot, thinking on your feet early on in the semester. So I tried to do at least 2 a week in first and second semester, and also to cover a wide range of conditions. So, do some renal ones, make sure you do cardiac and breast stuff, do some stroke or some cerebrovascular, MS. Make sure you can do a diabetic history very, very well. Always seems to come up, and obviously cancers. Ask interns and registrars on the ward who's a good patient and say, can I come and present to you afterwards, if that would be all right. Even presenting to friends is really good because the friend can be listening and then ask questions herself or himself to help you along. So in general, I think that the really important things to set you apart from each other is to really just show that you're thinking about differentials early on. Like what Boaz was saying, about, you know, saying your relevant positives and negatives. Don't be obvious, you know, basically just show that you are thinking about it. Because I think, that's pretty important. All right, I don't have great advice on the day. So I think mine was a really complex one on the day, the history. So I reckon I spent 50 minutes on the history and then 10 minutes on the exam. You can super race through your examination. Mine was a neuro case and I just did a really quick, well obviously it was okay my exam, but you know, quick upper limb, lower limb. And then it doesn't take very long to have a really quick listen to the heart, the lungs, that kind of thing. So I think that, you know, 45, 15, 50, 10, you can get away with it, just. So in terms of the 10 minutes before the presentation, you're obviously really nervous, so just try and stay as calm as you can. By that stage, you'll know what their history presenting complaint is and their past medical history, and if you work off of manila or off a piece of paper, it'll all be there. So just think about what your introduction will be and what your summary will be, because this is the first thing that the examiner hears, and you know, if you sound really good, like you know what's going on from that get-go, I think it's pretty boring listening to a long case, so I think they probably, you know, just fade off a bit. So just make sure your intro and your summary are really good. And then think about your differentials, like don't freak out about it, just have a really just calm down and think about what your differentials might be and how you would justify them with certain investigations. And then your issues, like what Boaz said, I think if you just stick to short-term, medium-term, long-term, psychosocial, you can't really go wrong.
And just really quickly, I'll try not to repeat stuff. So it's July now. Develop a consistent template for your long case and use the one that works best for you. This is really important because I don't think I got my structure down pat until about August. So if you're still experimenting, just try to find something that works. There's no one, whatever works for you, and then stick to that and just do heaps of long cases. Present to registrars and specifically request feedback and ask what they would do to add or to do differently. So you know how I've presented to registrars, one helpful thing is you go find them and they're like, oh, I'd like to see a patient for a long case, and like, oh, maybe this person. And then at that first point of contact you say, if you're free later in the day, can I come and present to you? And so you lock it in then. Then you come back, they might be busy, but eventually you can present at some time. And then some registrars just go, oh, that's, really good. Or just they just give you that sort of general feedback, which isn't helpful. So you're like, if you were doing the long case, like, what would you add to this management? Or what would you do differently? And you pick up things that you don't get taught in the lectures. And then I just take that on board, and next time I do a cardiac case, I just regurgitate whatever they said too. So yeah, use your registrars well. Do 1 to 2 long cases a week. You know, you can do it with a friend too. You know, sometimes what I did was, you know, you do a long case, meet back, be like, I'll meet you at 1 hour in 1 hour and a half time, present to each other, ask each other questions. The other helpful thing that you can all do is prepare a general management backbone plan by systems. So things that you could probably see in a long case: MI, heart failure, COPD, AKI, CKD, IBD, diabetes, cancers, whatever. So I'll give you an example. So I prepared one for each system. So this is an example of a chronic kidney disease one. And so confirming it, identifying reversible causes, prevent slowing progression of disease, treat complications, review meds regularly. When in doubt, offer counselling as required. So everything, so I had a plan for each common sort of long casey type cases. And so that I wouldn't be thrown. This is a general backbone. And then in your social history, as you pick up on the little like, oh, I like playing lawn bowls, or I live alone, then you tailor it to that patient. So you have the general backbone for pretty much all the things that you can anticipate. And then you're like, oh, I have 5 points, and I'm just going to tailor it to that patient now. So she lives alone, you know, make sure that she has supports at home, or she has depression, therefore offer her counselling, or things like that. General tips on the, so that was preparing for it, and then on the day, time management. Yeah, I agree with 50-10 because that's what I did. This is just like yeah, you can do it in 50 and 10-minute examination, but 45-15 is a more safer split. Sneaky, you can do this like anything that I should have asked you that I haven't asked you, like or like anything
you've told doctors that you haven't told me.
It's like anything I might have missed, always ask that after you take the history. 10 minutes, yeah, same thing, write your 3 differentials down, write your intro, jot down your managements. Don't worry if you don't, I've already said this, don't worry, some people got like osteosarcoma, Beck's disease, respiratory, that was me, aspergillosis. The consultants don't expect you to know these, they don't know them themselves, and they will ask fair questions. So with this aspergillosis case, I had 2 like gastrosurgeons and like, so tell me about nutrition. So, yeah, so don't worry about that. Now we're open to
Questions.
any questions from the floor.
Do you guys get access to the actual like drug charts and logs for the patients?
Yeah.
Yeah.
Yeah, so that's actually a really good thing because if you can see someone's drug chart, you can work out what medical conditions they have. So if they forget something, you can say, oh, why are you taking metformin? Diabetes, there you go.
So would you look at it before you actually speak to them?
Yeah.
I did it like, I'd be
I
like, so
quickly
tell me
scribble
what's
it.
brought you in.
Yeah.
Yes? And I'm just like looking at their med charts and writing them down.
Yeah, quickly writing them down. Yeah.
Yeah.
This is a stupid question, but do you write as you go or do you write down after?
Right as you go.
As you go.
Yeah, okay.
Unless you have a really good memory.
Yeah.
Is it important to say drug doses? Because I've had varying opinions on the two doses.
Yeah, I always say them, and I said it in my long case at the end of the year. And I think I was actually told that it's important to say the dosage. I think it sounds better. It takes a longer time because you have to write down it all onto your long case sheet, but I think it sounds better.
So this was like a model sort of what you should do. So I put the doses in, but in my long cases last year, I'd just like be like, they're just taking sertraline for this and this and this, and then I wouldn't actually write the doses down, but I wouldn't say it because but if they ask me, I'm happy to provide doses. But I was just like, yeah, they're on candesartan for the.
Yeah.
But yeah.
Do you get to take things like the drug chart and the ops chart in with you to your presentation, or do you leave everything but your own notes outside?
We have to leave it
Yeah,
behind.
you just get to take in your pieces of paper.
How do you save yourself in question time?
Like the way I do it.
I got cut off straight away after I did my differentials. He goes, I'm like, so in terms of my management, yeah, that will be fine. So now, tell me about nutrition. But it depends on the consultant. They might let you, but if you're firm, maybe.
Yeah, you've got to be firm in your long case. Like, no, but not too much. But I think if you, like the way that Boaz did his, he said, these are my management issues. But if you say that these are my issues 1, 2, 3, 4, would you like me to begin with my first one? Most of them say, oh yeah, okay. And then you just go through it. But obviously, like you need to be pretty confident and comfortable discussing your issues. But I was so nervous about the questions, but I think it's not something to be worried about. They're pretty fair, and they honestly don't know about the weird stuff, so it's okay. I don't know if you found it. Yeah.
I think we got shown a long case example video where the examiner provided an X-ray and you had to read it. How common is that for that to happen?
It's pretty keen, I don't think. Potentially an ECG, but even that, they're all freaking out. No, I didn't hear anyone at Royal Melbourne getting that.
Yeah, thanks. I don't think anyone got investigation, interpretation.
I think you get a lot of information when the patient knows about their disease really well, and I think it's really impressive when you list all these facts. But do you think it's a disadvantage to you if the patient doesn't understand their disease really well and can't answer all the questions that you want to get?
I
Yeah.
no,
Firstly, they screen. They do long cases. They find the good long case people first, and then they'll take a history and do the examination first before they qualify as long case examining patients.
Yeah.
So there's some degree of standardization there, but I don't think if they don't know about what specific blood tests or what specific, it doesn't matter.
Just say that, yeah.
It's whatever you are told by the patient.
Yeah.
You're not going to have their notes.
I know that Royal Melbourne put a lot of emphasis on finding good patients for our long cases, and most people, you get English speaking, not demented, not delirious patients who are aware of their medical conditions. And if they don't really know when they were diagnosed, just say the patient was unsure as to the date of diagnosis or the year of diagnosis. Just show that you've asked. But if the patient doesn't know, that's not something that you can be penalised for.
You get given a patient though, don't you? You get assigned.
You get allocated, don't you?
Yeah, but say they don't know what date
Yeah, that's
or
fair.
what year they were diagnosed with their hypertension. You could just say the patient was unsure as to the year of diagnosis. Yeah.
Is there a clock in the room? Like, how do you know how long you're going for?
You're wearing a watch.
Then I give you like a 2-minute warning or anything?
They do give you a 10-minute warning.
Yeah.
Yeah.
One more question. Have the actual examiners, before the examiners actually see you, can there be properly briefed about the patients and the presentations and conditions? Like, if I find something which I'm not sure about, can I kind of just ignore it and hope the examiner won't ignore it? Like, do the examiners know the patient's history well before you speak with them?
Yeah.
They've already done a mini long case on all those patients before.
It's kind of like a hypothetical, but just in the light of it's July and we've got to start preparing for the end of the year now. I think since the early hour, you kind of just have to know, you have to have your theory kind of down pat. So when you talk to a patient, you know how to talk to them and ask the right questions and examine them properly. So supposing right now we're not great at that, would you recommend getting on top of your theory first and then going practicing long cases, or
do it together?
Learning by doing
You
long
have
cases?
to do it together. So the moment you go see like this week, whatever patient you've seen, go learn about that case and how they present, what symptoms, what are the managements and investigation for that case.
Okay. So you recommend learning by doing long cases?
Yeah, I really think that you really have to be doing, like Boaz said, 1 to a week from now.
Yep.
And I think it really shows people that didn't practice, not to scare everyone, people didn't practice last year, it really showed at the end of the year and they didn't do as well. So I think it's really important to practice and also just to get your structure down. Because me, Boaz and I do long cases differently, but that's the way that we all, we'll do every long case so that you don't miss out on anything. And if you don't practice that, then you could potentially miss out. You might know all the theory, but yeah, no practice.
One comment on the systems review. The systems review is mainly for you, your benefit, so that you catch things that you might have otherwise missed. But you don't have to go and be like, oh, this from head to toe, I asked about headaches and eye symptoms and this and this and this. They don't care. But if you pick up on something that's relevant, you bring that up to the history of presenting complaint. Yep.
Yep.
Will the PowerPoint be available?
Oh yeah. I should have left the chart.
Yeah, so putting the computer away. All good?
Hey guys, I'll release the PowerPoint slides onto the Facebook page and we'll release it onto the UMMS website as well. Can we thank Boaz and Lucy again? If you have any specific questions for Boaz and Lucy, feel free to contact me or go straight to them. The email is just education@umms.org.au. I'll try again now.
Thank you.
say